Oh, I am screen
Yes, it is shared.
Where's my, oh, there we go.
Start the presenter view when you're ready. Yeah.
Okay.
Thank you.
Oh, excellent. Okay. So today we're gonna talk a little bit about evidence-informed practice and then critical appraisal, because the point of today was kind of how to prepare a journal club or how to prepare a critical appraisal, which Hanifi is going to show us an excellent example of in approximately 1 hour. Anyways, okay. So for those of folks that are new, that don't know that I don't have like a clinical area of interest in the NICU. Like I'm not a brain person, I'm not a lung person. My area of interest is critical thinking and evidence-informed practice, mostly critical thinking and various metacognitive stuff. And so as part of that, I think it's really important to understand that when we practice medicine, like the reason AI is never going to kick us out of practice is because a lot of what we do involves interpretation of imperfect information, right? Imperfect clinical information, imperfect science that tells us what to do, right? Every baby is both the same as every other baby and different than every other baby, which is how come, you know, we sometimes have to act based on insufficient information, and certainly insufficient information about a lot of the interventions that we do, right? There's only about 5 medicines in NICU that we actually use on label. Most of the medications we use are off label, right? A lot of the things that we do haven't been very well studied. It's getting better, but it's also hard to study because we've addressed all the low-hanging fruit. So we have to keep an open mind, and we have to make sure that we do use the best available information that we have. So when we talk about critical thinking really is about applying the scientific method, like we use when we do a trial, to every decision that we make in medicine. So when we think about like asking a science question or asking a research question, we should be going through those same questions, those same things when we're trying to figure out why our baby's having apnea, or when we're trying to figure out what to do with the ventilator. We want to make sure that we clearly understand exactly what the problem, question, or decision that we want to make is. When we talk about events, for example, what exactly is the event? Is it a desaturation? Is it a bradycardia? Is it both? Is there an apnea? Is there underlying lung disease? Like really, what is the question? We need to make sure, and especially like when we're talking to nursing, or when we're talking to somebody, or when we're trying to evaluate an infant, that we do actually understand exactly the problem we're trying to address, because they're not all the same. That we're well aware of our current biases or what we know about the topic, and that we're, you know, if we, you know, for example, like once you've seen a baby that's gotten really sick from sepsis, every baby has sepsis for like the next couple of weeks, right? So you need to acknowledge where you're currently sitting. And that includes your underlying assumptions or biases. For example, we had a baby last week that had bronchiolitis, and we were managing bronchiolitis, and we kept managing bronchiolitis. And then the responses we were getting they didn't match the story of bronchiolitis. So we had to, again, step back, think about where our assumptions were, and then kind of restart from the beginning. And then once we did that, and we didn't kind of keep down this path that we'd been set on, we realized that there was something else going on. We want to pay attention to all the information that we have available. So specifically, if you think about when you're designing a scientific question, what you're really talking about is rejecting the null hypothesis. The null hypothesis is that treatment A is the same as treatment B. And what we're trying to do is we're trying to do a trial that will either tell us to accept or reject the null hypothesis, right? So when we're examining an infant, we should be doing the same thing. If I'm seeing a baby for increased apnea, what I'm actually looking for, you know, I've figured out my differential diagnosis in my head. What I'm looking for when I'm looking at what's going on, I shouldn't be looking for things that support my first thought that this is just, apnea prematurity and they need more caffeine. What I really should be doing is, if my first thought is, oh, they just have apnea prematurity, I should be looking for evidence that disproves that. I should be looking for reasons why the things that I think are going on are not true, because that way I'm not going to create a confirmation bias and following where we go. again, if Iman schedules it, I got a whole bunch of different lectures on cognitive reasoning and bias and logical fallacies. But again, we need to kind of, right, everything that we do should be completely internally consistent. So we shouldn't have information in there that doesn't fit with kind of the framework of thought that we're doing. And when we're, and how we apply these critical thinking skills to the practice of medicine has evolved over time. So especially in an ICU, where we're in, neck deep in Cochrane meta-analyses and all the Cochrane evidence. For a while there, we had what was called EBM, right? Evidence-based medicine. And evidence-based medicine was this kind of, for lack of a better term, the kind of worship of the randomized controlled trial, right? Everything in medicine cannot be tested in a randomized controlled trial because A, sometimes it's just not possible, right? B, we don't even actually know the exact population that we want to look at. So for example, we're still trying to find, and we're going to talk today, Hanifi's got a great article on vitamin A supplementation, right? We're still trying to figure out how we can reduce our rates of chronic lung disease because we think we can get them lower. And we know we can because there are centers that have lower BPD rates than other centers, even after you adjust for the differences in centers, which means we're doing something different, or our babies are different, or there's something different about places that have more chronic lung disease than other places. But we keep doing these trials to try to randomize controlled trials to try to figure out, what can I do? Can I give them INO? Can I give them different doses of steroids? Can I give them vitamin A? Can I give them more fatty acids? Can I can I extubate them sooner? Can I extubate them later? But for various reasons, we can't find the answer. And so when we're evaluating a trial, whether a trial shows us a difference or doesn't show us a difference, it's important to kind of think past that as to why, right? Why have we, if it's physiologically possible that we should have seen a difference, how come we're not seeing a difference? Is it because physiology doesn't always tell us the answer? Is it because of something about our patient population, right? So it's really important to think through whatever studies you're talking about. So the somewhat infamous parachute study, right, is this idea that some things you don't need a randomized controlled trial to say something's useful or not useful. That's not to say that we can jump from a basic bench science or physiology-based rationale to say that something's going to work, but it's to say that every piece of information that we have in the medical literature can be used to inform our practice. It doesn't just have to be an RCT or a meta-analysis, right? There are epidemiologic studies, population-based studies, those studies, case control studies, those studies have information to tell us, but what we need to do is understand how to critically appraise the information that we have available and use the good information from that data. But yeah, so this was like, there were no randomized controlled trials of parachutes, so therefore we don't know if parachutes are helpful. Well, of course parachutes are helpful if you're jumping out of a plane, right? This was actually published in like in the Christmas joke.
What's the BMJ does it?
Yeah, it's BMJ.
Yeah.
So the other the other kind of science that we really have to be careful of is something that Harriet Hall, who's a retired, I think she's a surgeon actually. Actually, I think she's now deceased, but anyways, is tooth fairy science. So tooth fairy science is when we jump into studying something before we've actually established that said thing actually exists. So her idea is, right, so you could figure out how much money the tooth fairy leaves based on what tooth it is, or what kind of day it is, or how old the person is. So we're kind of establishing the different ways the tooth fairy works, but we haven't actually established that there's a tooth fairy to begin with, right? And so this is similar to things like studying different types of acupuncture. When you actually evaluate acupuncture at its base, we haven't actually proven, like acupuncture has never actually been proven to do anything when you actually study it properly. So we have to establish that something actually exists or works before we study the different ways that it works. That whole idea is a little bit kind of more applicable when we talk about, the perils of complementary and alternative medicine, or whatever we want to call it now. But again, you know, everything that we need to do, we need to kind of roll back to its basics and work our way up from there. So evidence-based medicine, as it officially started, you know, again, I'm not trying to say that evidence-based medicine is bad, or what we call evidence-based medicine. It really introduced this idea that you shouldn't do something just because the senior consultant told you to do it that way, right? You shouldn't do something because it worked on the last 5 babies that you did, because you don't actually know. It brought this idea that we should study things, right? We should do randomized controlled trials, especially of the things where it's relatively easy to do a randomized controlled trial. And that's led to actually like rejection of some things that we actually thought were beneficial. Now, it takes about, they say, 20 years for some a randomized controlled trial to change actual practice of medicine. But I think we're getting better at that, right? It's led to this idea that like not all published studies are created equal, right? Especially nowadays. Just because a study is published in the literature does not mean that that is a good study. I mean, even, you know, the so-called prestigious journals have fallen prey to publishing studies that are methodologically poor, or where the conclusions that are drawn from the study don't actually come from the evidence that's presented in the study. And they have also kind of, you see, I have pyramid of evidence on both sides, the good and the bad. They have kind of given us this general idea, right? That a case report or a case series is kind of at the, like anecdote is at the very bottom, right? And then your case series, and then, you know, your larger case controls, your prospective cohorts, your population-based studies, your randomized controlled trial, your, you know, big meta-analysis, your individual patient meta-analysis. For sure, you know, your data gets more robust, and the conclusions you draw get more robust as you go up. But there's also this thing called garbage in, garbage out, right? If you take a bunch of really poor studies and do a meta-analysis, you haven't actually, you just now have more garbage, right? Or again, just because something hasn't been studied in a randomized controlled trial doesn't mean that we can't use that information to inform our practice, which is the kind of pitfall of this, the pyramid of evidence. The other thing that a randomized controlled trials sometimes do is they kind of fail to account for plausibility. Is this even possible that this might work? Or prior knowledge that we know, or they don't use what's called Bayesian statistics, right? The fact that something, the kind of pre-test probability that something's going to happen doesn't come into play when we just look at the base odds ratios or relative risks or numbers needed to treat from trials. And then it's led a little bit to the worship of the RCT and meta-analysis. And the other thing that I think I teach clinical reasoning to first and second year medical students, and I think you know you folks are far enough along that you're coming to realize that we really want to know for sure what's going on, right? We're not very good. People who go into medicine tend to be very high achieving, and we like to know what's going on, and we want to know for certain. But the more we practice, the more we know that in uncertainty and not knowing exactly what's going on and having to make decisions with imperfect information is an inherent part of medical practice. And it's part of why, again, AI is not going to replace us in medical practice. And it's part of, you know, it's part of this idea. Some folks in here, some of the science-based folks don't like the kind of analogy that science is an art, but it's not an art in that you need to have some sort of innate skill to practice it, but it's an art in the same way that any skill is an art, in which you need to practice, you need to think through, you need to hone your skills, you need to be exposed. But, you know, my father, who was an engineer, used to laugh because he also would say that medicine is not a science, because, you know, my babies are all different. They're not all exactly the same. I can't do a trial with, right? The reason why in medicine, our trials have thousands of children in them and not 10 is because I don't have 10 exactly mice that are exactly the same as the other 9 mice, right? It's not, we can't. And that's one of the reasons why it's getting harder and harder to prove things in RCTs, because the exact subpopulation that is going to respond to whatever this intervention we're talking about is getting smaller and smaller, right? Even if you only enroll kids between 22 and 25 weeks, those kids are all very different. They come from different backgrounds. They're delivered for different indications. They're different weights, especially when we talk about things that happen outside the NICU. They're going home to different environments. They have different family structures. And so, you know, even the small things that we do are going to change. So the idea of what, you know, some folks call science-based medicine as compared to evidence-based medicine, or some people call it evidence-informed practice instead of evidence-based practice, is that we need to use the best scientific evidence we have available to inform our practices. So it builds on the idea of evidence-based medicine. It allows you to take into account other types of evidence in your practice. It requires that what we're talking about not be implausible, right? So homeopathy, as it truly exists, for example, is completely implausible, right? It's this idea that you dilute something down so there's actually not even a molecule of it left in the water, and that the magic water is going to change what happens. Well, that's actually not, like, physics does not allow that to happen. So I don't need, right? I don't need an RCT of homeopathy to prove that it doesn't work, because it's actually not physically possible that it could work. And that if you're going, you know, but just because something physically possibly could work, or we've proven something outside of the lab, is one piece of information, and that may be all the information that we have available to us to make a decision. But if we have kind of better evidence, then we should use the better evidence. So applied science, yeah, so it's Harriet Hall that doesn't like calling medicine an art. I mean, I think it is a bit of an art, but that was her take on it. It's not intuition, right? Like, intuition doesn't actually exist. Intuition is essentially your subconscious brain working with the information that you have available and making connections that you're not consciously thinking about. Sometimes, right? So really what we're doing is we're using the evidence that we have to apply it to an individual patient. And when we're appraising a journal article and we're presenting it at Journal Club, part of that process should be taking the evidence from that article and applying it to our patient population, because wherever you're practicing, the patient populations are going to be different. For example, we have a relatively low rate of fungal sepsis in Winnipeg. So many trials that look at the benefits of antifungal prophylaxis don't apply to us in the same way, because our number needed to treat would be so much higher because our base rates are lower. When we talk about congenital screening for pulse saturation screening for critical congenital heart disease in Manitoba, we have a very robust antenatal screening program for critical congenital heart disease, in which they up-trained our techs at regular ultrasound folks that do the 20-week scans. So our rate of undiagnosed critical congenital cardiac disease is much lower than in other centers. So therefore, right, the risk benefit of applying pulse saturation screening is actually different for us. We have so many more false positives, because our background rate is so much lower. And these are the kind of things, as you move through appraising the literature, that you have to look at the literature in the context of what's going on. So medical science is flawed, but it's better than the alternatives, right? And again, we need to acknowledge that. We do many things in practice that actually haven't been, when you actually study them, don't actually pan out. So I mean, how many kids in the unit right now are on pump feeds for apnea? Many. When you actually study pump feeds for apnea and reflux, it doesn't actually show any difference. Yeah, we are very convinced that it does. We continue to do it because the drawback of it is relatively low, right? The one drawback of it is that it can cause your babies to not gain weight as well. But we do seem to think it's working. Now, is that because the trials themselves don't apply to our patient population? Is that because, right, the number needed to treat is so high because the differences are so small? We don't know. Do we need to invest more time in doing more trials of that when, you know, we're doing the practices? When we look at the kind of, you know, right, the scarce resources, talk about, right, scarce resources and doing trials, it's probably not super important, but we should acknowledge that we do things. We give Lasix we give diuretics for chronic lung disease. They've never been proven to change the rate of chronic lung disease either, right? We do many things in practice that are not supported by evidence, but we need to acknowledge that they're not supported by evidence. So there's a couple of different topics in science-based medicine. I'll move on to kind of how we're gonna critically appraise our articles, but these are some different topics that we can talk about. And going through there. So one thing that I think is really important when we talk about journal appraisal in academic sessions is that when you're choosing an article to critically appraise, I would suggest you refrain from, oh, this is a really good article, or this staff Neo sent me this article to appraise, because what we really should be doing is we should be linking the critical appraisal or the evidence that we're looking at to a clinical question that came up in practice. So, any questions about that before we go on? I'm just going to go through my suggested, I can't see the chat if you're typing in the chat, my suggested kind of format for preparing a critical appraisal. Questions online? We just have these folks?
No, I don't have any question.
Okay, I thought you'd be here, Hanifi.
Oh, I'm on call here. That's why I'm in San Boniface.
Of course you are. We let you go home all weekend?
Yeah, I know. It's busy.
Okay. So your first slide is right, just the title of the paper that you're reviewing. And then again, I think it's important that when you present your paper that you've chosen for Journal Club, that you tell us why you chose this paper, right? Because that is important as well. Is it because there was a clinical question that came up in practice? And that's a really good thing, right? Did you have a problem with a baby that you wanted to know why? Did your attending suggest a form, like suggest something to you and you don't understand the evidence behind it? Did you do something different where you came from before that is different than how we do it now? To me, that's the best reason to choose a paper. Sometimes it's because it looked interesting, right? It came across in your, table of contents. Someone suggested it. It's an area of interest of yours. It looked new and exciting. Or sometimes it's because you wanted to talk about one aspect of it. So it used a statistical method that you weren't familiar with. Or it was a type of trial that you've never seen before. So like there's more like non-inferiority trials or kind of other kinds of trials. Maybe it wasn't just your kind of straightforward RCT. I would encourage you to choose papers that are not just, usually we talk about papers that are on evaluation of some treatment, right? It's also really good to look at different papers of long-term outcomes, to look at papers of diagnostic tests, to look again, like any kind of an epidemiologic study. And you can always find, if you find a paper that you want to talk about and there's bits of it that you don't understand, there is a neonatologist around that would know about that, right? We all have our different areas of expertise. Shamil is a basic science researcher. I'm an epidemiologist. There's all the cardiac folks, all the TN-ECHO folks who do that. Ganesh and Mansoor do kind of neurocritical care stuff, right? So look at the stuff you're interested in. Cecilia does follow-up stuff. So there's all of us around. Molly just knows everything about everything. So we can go from there. And then I'm sure everyone's seen this before. What is the question that the paper is asking in your PICO form, right? What is the population? What is the intervention? What is the control group? What is the outcome? And over what time? And then it's helpful, and this is like a little template that I'll send you around so you can just plug your presentation into it. It's important before we talk about an article that we know, what do we already know about this topic? So this may require you to either just read the introduction to your article, or maybe do like a brief little search at what else we know. Some of the articles often now have that little like box that's like, what do we know about this topic now? What does this add? But it is important that we kind of know what the current state of knowledge is, because that's how we also figure out how we're going to integrate whatever this article tells us into what we currently know. If this is kind of a first kick at the can for something, what is the preclinical data? What's the animal data? What's the physiology data? What's the kind of rationale for why this exact intervention is being done? Why am I worried about the effect of caffeine on long-term neurodevelopmental outcome? Right? That was a significant concern when they did the caffeine studies. That it might actually be worse if they're having lots of events and we've constructed their cerebral blood flow, right? So there's all sorts of questions that come out of stuff. And then again, what is this paper trying to add to our knowledge? Replication is very important in in studies, and we have, right, we have a lot of studies that aren't being replicated because nobody wants to publish a replication. But we need to identify what this trial is adding, especially again, if it's a repeat of an RCT that's been done. Does it have a larger sample size? Is it a different patient population? Did they use different outcome measures? Is it a replication? What knowledge was this paper trying to add? And then what type of study is it, right? Is it an RCT? Is it a cluster RCT? Is it an individual RCT? Is it a case control? Is it a population-based retrospective or prospective cohort? And then again, depending on what kind of study it is, especially if it's kind of not your run-of-the-mill RCT, what are the pros of this kind of study? And what are the cons of this kind of study? Because every single study has pros and cons. Even your like gigantic multi-center RCT is going to have some drawbacks. And then kind of before we talk about it, are there kind of any big glaring issues in the methods that you came up? And you can use whatever, there's like different checklists that you can use, right? You can use, there's different checklists for different kinds of studies that you can use to kind of evaluate how they're reported. And you can use those again to help you structure your analysis. And then an overview of the methods. We do hope that when you present to Journal Club that you've circulated the journal and that folks that have come to your Journal Club have read said article. Sometimes they haven't. So in Journal Club, you shouldn't be like essentially just presenting the information that's available in the study. You should, right, part of Journal Club is critiquing the information that's available. So again, an overview of how the study was conducted and any kind of issues with the methods that you found. So when we talk about the population, any trial, so using Hanifi's going to use the consort checklist to talk about the reporting of his RCT. For epi studies, there's strobe checklists. There's other checklists for the different kinds of ways that things are reported. Every trial should have that enrollment flowchart, or whatever kind of study it is. And it's important, again, that we look. So when we're talking about the population, right? Is the population that was enrolled in the study representative of the population that they're trying to draw conclusions from? Because that is one of the drawbacks of RCTs, is that often the eligible population is so much larger than the actual population of kids that you're going to see outcomes on, because kids are not enrolled because of non-consent, right? Often, especially when we don't still have clinical equipoise, right? Clinical equipoise is when people feel that both paths are equal. If we wait too long to do an RCT and people are already too invested down one pathway, they're not going to enroll all the kids. They're not even going to like put forward for enrollment a lot of the kids that are eligible, because they actually think that either the thing that's being studied is beneficial, or they actually don't think it's beneficial and they won't enroll folks. So that's something that happened with the steroid trials originally. The postnatal steroid trials is people thought they were very, very helpful. And so all the kids were getting steroids, right? People weren't enrolling them in the study because they didn't want them not to get steroids. The HIE cooling studies only barely managed to get finished because people saw the benefits of cooling, right? And didn't want to not cool their kids. So, right, we had to gather that evidence before we were kind of past the point of no return, where people would not randomize kids because they were, right? And so if your population that's being randomized is not representative of your overall population, if it's a cherry-picked population, your results are not going to be generalizable. And that's one of the biggest issues with randomized controlled trials, is that they are such a tiny subset. Was there a discussion of sample sizes or a calculation of sample size? People pay a lot of attention to that, and that's important, especially if your study doesn't show any difference. If your study showed a significant, both statistically and clinically significant difference, that doesn't really matter what the sample size is, because the sample size was big enough to show a difference. But if your trial hasn't shown a difference, is there some way of saying, yes, that difference is actually not there because I did have sufficient kids in my study that I trust this, right? I trust these results. And then the ever so famous table 1, right? So table 1 is your table that tells you about the kids in your study. If it's an RCT, are your two groups the same? Are they the same weight? Are they the same gestational age? Do they have the same C-sections, the same antenatal steroids, right? So stick up your table one and kind of for two things, were the two groups the same? So if regardless of the type of study, whatever comparisons you're making, your two different groups that have been exposed to two different things should be the same. And how do these babies differ from our patient population, which again is very important. You know, is this a center that has a lot of smaller babies than we do, right? Because in general, we don't actually have that many small babies a year, right? Our proportion of really little babies is lower than in some centers. So if we look at all kids under 28 weeks, our number of kids in the 22, 23 week range is like proportionally lower than in some other centers. So, right, if our patient population looks different, you know, there's evolving discussions about the importance of self-identified ethnicity or race in studies. But if your patient population is very different, so if the Black or Indigenous populations differ dramatically between us here and the center you're looking at, there may be some differences. Is the socioeconomic breakdown very different in different centers? So that's important when we're going to get to how does this data help inform my practice here. If they're not comparable, so let's say, you know, you have your two different groups, and one group is proportionally, they have a much higher rate of SGA babies in one group than the other group. Then you have to ask yourself, okay, if this group differs from this group, how is that going to affect my outcome? So if these two groups are different, how would that affect my outcome? So when I'm talking about my outcome, I can figure out how it may have been skewed because my populations were different. And then sometimes it's happening more and more in randomized controlled trials. They aren't just presenting their randomized controlled trial data, they're then running their randomized controlled trial data through some sort of statistical model to adjust for any differences at baseline. So did they do anything like that to try to make their groups even more similar? Talk about your intervention in your control group, right? What were the indications to enroll the kiddos? What were the indications for if it's an intervention? Were all the groups treated the same in all the ways? It's very common for some studies to do especially when we can't do an RCT, a lot of studies now are like before and after comparisons, right? So we have some epoch historically where kids were managed one way, and then they've changed their management, and now they're comparing those two different groups. Again, a lot of the time, that's going to be the best evidence that we're going to get to test an intervention, right? That's kind of where we are in the management of PDAs at the moment, right? That swings around back and forth. We still haven't decided exactly the best way to manage a PDA. Should we screen for it early? Should we screen for it late? Should we treat it? Should we not treat it? Should we surgically ligate it? It's something where we're not going to be able to do a randomized controlled trial. So we do end a lot of, right? We compare times in which we screened early for PDAs to times in which we screened late for PDAs. Times in which we treated a PDA even if it was there, to times in which we treated a PDA based on hemodynamic indices. So if we're making those comparisons, what else may have changed between the two time periods? Are we using antenatal steroids differently? Are we ventilating our kids differently? Are we feeding them differently, right? Do we have more TN echo folks? Are more babies getting echo? So again, to use whatever data we have to know how our group's different and how things may have changed over time. And so we should be talking about that when we're talking about our studies. The primary outcome, right? Every trial should have a primary outcome, whether it's a follow-up trial of, you know, HIE cooled kids, whether it's a BPD trial for prevention of BPD, whether it's, you know, this test, we're comparing the utility of a point of care ultrasound to X-ray for the diagnosis of pneumothorax, right? How is the primary outcome being measured? What is the definition? And the first thing is how do they define the primary outcome, right? And we've learned more about this when we talk about, for example, when we talk about chronic lung disease or BPD, right? How exactly is it being defined? Because if it's not being defined the same in every baby, then we don't have a reliable measure of our outcome, and that's going to skew our results. Is it an important primary outcome? So that's going to vary from different folks, right? We have this back and forth in neonatology about, you know, what primary outcomes are important. We've kind of moved towards not caring about a lot of kind of outcomes at discharge and moving towards long-term developmental outcomes. But that makes it even harder to gather any information, because if we're just looking at long-term neurodevelopmental outcomes, we don't even have those until at least 18 months. And now really your 18-month outcome isn't very good. Okay, so I need a 5-year outcome, right? But by the time I have a 5-year outcome in a trial that's going to take 10 years to get finished, what else has changed in the 10 years since we started this trial, right? So sometimes, again, sometimes the kind of earlier primary outcomes are important, right? How long they're ventilated, whether they needed ligation for PDA, how long they stayed in hospital, those kinds of things. And is it a clinical outcome or a surrogate outcome? So sometimes, right? So sometimes when we're talking about prevention of BPD, we're using a surrogate outcome. We're using days of ventilation or failure to be reintubated or things like that. And that's okay too, because again, that gives us different information. Are there any secondary outcomes? Again, how are they defined? Are they defined the same? Are they appropriate secondary outcomes? Are they important secondary outcomes? There's also kind of more interest now in trials in looking at outcomes, especially when we're talking about secondary outcomes that are not the kind of medical secondary outcomes that we tend to focus on, but secondary outcomes that are more important to families and other folks and communities. So length of stay, in and of itself is important. Readmissions to hospital, support outside the home, support outside the hospital that families need, right? Those kind of things are very, how kids do in school, not necessarily, the things we worry about, the kind of standard cerebral palsy, low MDIs, those kinds of things. Statistical questions as appropriate to the study. So you should kind of comment on how was the sample size determined? What statistical tests were used? Were those the right statistical tests? This happens not infrequently. Like, how many articles have you seen where they've reported APGARs with a decimal place? An APGAR can't have a decimal place, right? Your APGAR is 1, 2, it's an ordinal scale, right? So you can't have a mean APGAR, right? Because there's no such thing as a 1.5 APGAR. You should have a median. Were those used appropriately? Were there adjustments for multiple comparisons? And is the significance conveyed in things other than p-values? So if your study just reports p-values, okay, those are not very helpful, because p-values, again, we've extrapolated those suckers from actual real science, right? And just because something crosses 0.05, that doesn't mean it's real. Right? You want confidence intervals. So let's give you kind of a better understanding of what's going on, right? And also, just because something crosses 1 doesn't mean, right? That doesn't mean that it's been, disproven forever that it's not going to be real. The most helpful way to talk about, and probability, human brains don't do probability well at all, especially odds ratios. Again, the human brain cannot wrap its brain around an odds ratio. So really, we should be talking about number needed to treat or number needed to harm. And if your study doesn't report that, you should actually calculate the number needed to treat or the number needed to harm. So you should present your primary outcome table. And when you go through the primary outcome table, you should go through the results. What is the main finding? Did you accept or reject the null hypothesis? And then kind of from there, we want to go forward to kind of, again, if we haven't talked about, are there differences with our patient population? And then it is actually even better if you can calculate the number needed to treat or the number needed to harm for our patient population. So if our risk of BPD is higher than the risk of BPD in the group that you're talking in the paper, then our number needed to treat may be lower. Or if our outcome of whatever we're talking about, right? So for example, we're having a small issue with intraventricular hemorrhage right now. So our number needed to treat to reduce severe intraventricular hemorrhage may be lower, because our rates currently are a little bit higher than we'd like them to be. So this comes into play certainly when we're talking about things like probiotics, right? So the efficacy of probiotics for prevention of NEC, it's not actually all that well established for many reasons. But one of them is that the baseline risk of NEC varies quite a bit from center to center, and the baseline use of another huge risk factor for NEC is, right, human donor milk, exclusively human milk diets, and formula, right? There are many places, specifically in the States, where there's less support for lots of things, that, their use of formula is much higher, and their provision of just like parents' own milk is very lower. So, right, those kids are gonna benefit more from probiotics than in a center that's using exclusively human milk in their kids at highest risk for NAC. So those are really important things to think about when we start kind of figuring out how these results, whatever information we can take from this article, is going to impact our practice. Does our indication or use of the treatment differ, right? So if we're a center that has a higher threshold that makes that, you know, we use a lot more PEEP, for example, than other centers. So when we're defining BPD, we have many kids that are on CPAP that in other centers would be on oxygen. So, right, if that's an important practice difference, then we need to make sure that we account for that when we start talking about things. Our creep of using higher doses of caffeine, right? We use a lot of caffeine. We use higher doses of caffeine. We use mini loads of caffeine. We use caffeine differently than some other centers do. So again, that is going to affect our reintubation threshold because, right, how many events can we tolerate before we reintubate somebody? Especially, so reintubation studies are also an area where it's very hard to figure things out because the threshold for reintubation is different at different centers, and we don't even follow. We have guidelines for reintubation. We don't follow them a lot of the time either. Do we use different outcome measures? So again, look at the practice differences between your center and between any kind of things you can glean from the article. And then whatever critical appraisal template you're using, kind of are there other things when you look through the template that would make you think that this is a more robust study, or things that would make you concerned? Nowadays, right, if it was a trial, was it registered as a trial, right? Because if it's not registered, they may have changed their outcomes based on their trial. They may have changed their protocol, which is fine if it's acknowledged that they changed it for these reasons. For a meta-analysis, you want search criteria, right? Did they use good search criteria? Have they, are they including just English language articles? Because we know that that's exceedingly problematic. Sometimes you can't, if you don't have people in your, right? If you can't translate your articles or you don't have access to the other articles, you're not. But again, that should be noted as a weakness. And then sometimes it's helpful for things that look at cost effectiveness, right? Like if we gave every single baby an exclusively human milk diet, we would reduce our incidence of NAC even further. But at some point, especially in a Canadian healthcare system where we are looking at, managing a scarce resource, i.e. healthcare funding, sometimes we can't, right? We don't give all of our kids human donor milk because we only use it in our highest risk kiddos. Now, we upped that criteria a couple years ago to allow for its use in more kids. And there's hopefully some discussion that we might be able to extend that even more. But that sometimes we do trials to just show how cost effective our different interventions are. Potential practice implications, you want to calculate the number needed to treat or the number needed to harm using our local data. And then I want you to answer, especially if this is something where you're looking at an intervention that we don't use or an intervention where things are different. Does this article change your practice? How is this article going to change what you do? What information from this article can you put into practice? And then any unanswered questions from the article or other things that it's brought up. And so then, if you want, this is my favorite thing to recommend for folks who want to learn about critical thinking. It's a podcast called The Skeptic's Guide to the Universe. They have a book called The Skeptic's Guide to the Universe. How to know what's really real in a world increasingly full of fake. Stephen Novella is an adult neurologist in the States. Super interesting. They're a super interesting group of folks. And they have a website called Science-Based Medicine, which is fantastic. And they write all sorts of stuff about science-based medicine. And these are logical fallacies. We also have a fun session called Name That Logical Fallacy that we will have to revise shortly because it's fun. Questions?
Like one study we do in the journal club. So another study has answered those questions. Can we credit that study as well? Journal club, like multiple studies. Like I am doing presenting one study in the journal club, and questions of the cons of that study are better in some other study. And can we like,
well, the pros and the cons of the study are like the pros and the cons of that type of study. So when we talk about the pros and the cons of the study, we're talking about there's two different kinds of pros and cons. We're talking about the pros and the cons of that type of study. So the pros and cons of an RCT, the pros and cons of a prospective cohort. So that I don't quite know how another study would be different than that. But if, for example, you have one study, like the question is, so in Journal Club, we traditionally present one article. Sometimes if you have a clinical question, you may find two articles, one that answers one aspect of the question and one that addresses the drawbacks of another study. So then, yes, you could talk about two. Is that your question? You could talk about two different articles. In the beginning, I would suggest that you stick with one article because that might get confusing. But yeah, but it's right. And then that would ask that study, whatever information that study gives you would be caveated in whatever the drawbacks of the study are, right? So say, for example, yeah, it was a study addressing the, the long-term outcome of stage 1 HIE kiddos that were not pooled. But their criteria for stage 1 is different than our enrollment criteria. So let's say then we would have to know that difference. And so then if you found a study that used different criteria, then those would give you two different pieces of information. And that's right. The point of critical appraisal isn't to like only rip apart how an article is put together. The point of critical appraisal is to get good enough at critical appraisal that you can go through it when you actually have to answer a clinical question. Because right, we do this in practice, right? I have a question, right? Like our kiddo with Bloom syndrome, right? I don't know anything about that. So I pull up information, and that information I have to critically appraise, right? Like when we're trying to figure out, is there thrombocytopenia associated with it? I don't have a lot of information. So I have to make the best, right? Take the best information of what I have, acknowledging the pluses and minuses, and then answer my question. And caveat it in the drawbacks of the question. I don't know if that answered your question or not.
Maybe what I was trying to say is like to implement something to our practice. So whatever one study is presenting, maybe we can come up, because one study has some goods and bads.
Yeah.
Another study has some goods
Hey.
and bads.
We have a meeting booked here at 3. Are you guys booking, do you have it booked till 3?
We have a book till 4.
Okay, all right.
Do you need a big room? We can move.
Well, I need a telehealth room because we're linking people.
This is a telehealth.
Or MS Teams,
Oh, yeah.
MS Teams, I need it linked to.
Can,
It's next door, does it have MS Teams?
next door has an actual telehealth, which you can put teams onto. But we can move. If you're more familiar with this room, I do not want to.
Our meeting has 6 people, so it's not like I need a huge room. I just needed something where I could get computer access and MS Teams linking. I'll try next Friday. Sorry.
No, that's okay. We're just chatting. I mean, we can move.
Mine's
Sorry to interrupt. We have the room until 4 p.m. And
Oh,
I think that,
I'll see what I can do. If it's a problem, I'll come back. Okay.
thank you.
Yeah.
Yeah, I mean, the next room has a computer and a screen, like the little one right there.
Great, and I hope it's not booked for anybody else. Thanks.
I know we have it booked, Chris, but I mean. A multidisciplinary team meeting looks like it's more important than anyways. Yeah, so, right, so again, we're just talking about, when I'm talking about changing practice, I'm talking about, right, is it going to inform your individual practice? If we're talking about changing, like making a bigger change in practice, then that involves more than one study, right? That involves a synthesis of the current and available information, which is an appraisal of each piece of information to change our practice. So, yeah, so like guideline development, right? Like if we're gonna have a sweeping change in practice, then we need to look at all the, right? And that's different than this one article, that may change a small aspect of my practice or may, right? Sometimes, like for example, when we used ibuprofen and medicine to treat a PDA, and then there was this like kind of emerging evidence that maybe we could use acetaminophen, which hurts my brain because I still, for this day, cannot figure out how acetaminophen closes PDA. Right? It's a good one, right? Because you needed to look at all the data, and we needed to have different kinds of data, right? We needed to have it against placebo. We needed to have it against other things. We needed to have, it would be ideally, right? We had to gather all that information, and then at some point, it reached the kind of critical mass of sufficient information that it became not just a second line treatment, it's actually a first line treatment in some indications, right? Because we've evaluated the evidence and right, the stronger the kind of, if something's really plausible and you do a really good trial, you need less data, right? But if something's kind of less plausible and the effect size is not very big, right? Then you need more data before you make a practice change. I don't know if that answered your question or not. Okay,
Fair enough.
anyone else? So for the fellows, I have the slides if you want to like use them as the basis for your journal club. Should we take 5 minutes and then Hanifi's gonna go?
Sure, yeah. I think they might need to go washroom or take a breath.
Yeah,
Okay, so should be 5 after
5
3?
after 3?
Yeah.
Do we have to change login links again?
Chris was asking me to log in, because it's not.
So should I?
I think we have to change.
Okay, I will do it. I'm just. I will log out and then.
Chris, do I have to change? Was Chris telling you to change here?
Yeah, because I think you will log out from your